Our next speaker is seated right behind me here. She's ready and excited to give her presentation. So next talk is actually something I think that we've, certainly I'm quite excited to hear. We've been touching briefly on JAK inhibition, but have not taken such a deep dive, and I'm looking forward to Vibeke's talk exploring the role of JAK inhibitors across the spectrum of IMIDs. Vibeke Strand is, I think, is yet another one of our speakers who really does not need much of an introduction, certainly not to the rheumatologists in the room, probably not the dermatologists, and so I guess I'm doing this for the GI folks that are remaining at this point. But Vibeke is does a lot of consulting work for new therapeutics in terms of clinical affairs and key regulatory strategy in rheumatology. She has been involved in essentially all of the new biologics in rheumatology, has a really extensive and very, very deep knowledge of our therapeutics in the space. And she is an adjunct clinical professor at Stanford, still sees patients, is incredibly well published, and is a fantastic speaker. And it's my pleasure to welcome her.
Thank you, Joe. So I want to tell you a little bit more about the JAK inhibitors, and specifically use of the JAK inhibitors, not so much in rheumatology as in dermatology and also GI. But I think that I had an enjoyable time putting this together, because what I was specifically doing was looking at all the other indications that are being thought about with the JAK inhibitors. So to examine the reasons why the mechanism of the action of JAK inhibitors or JAK-STAT inhibitors leads to efficacy across the diverse disease states, because I don't think we've seen that. We saw quite a bit, obviously, with the TNF inhibitors, but now we're seeing it, I think, even more with the JAK inhibitors. To review efficacy data on currently approved JAK inhibitors, or should we say one JAK inhibitor approved in the U.S. and one that we hope will be approved in the U.S. soon. To summarize trial data on emerging applications, and to review the safety data and adverse events that are associated with this class of therapies, because I think we can definitely plan on having at least 3 or 4 of these, at least in the United States, and probably similarly around the world. So I know you've seen very many of these different diagrams, but I want to try and explain it in a little bit simpler way. So we know that these JAKs actually associate, only one is a homodimer, the JAK2. And the JAK2 is actually associated with hematopoiesis and growth. So think about erythropoietin and thrombopoietin. Then we look at the JAK1 TYK2 heterodimer, and we look at Th17 differentiation. So that's also our 12 and 23 pathway. If we look at JAK1, which associates with JAK2, or JAK2, JAK1, TYK2, now we're looking at basically IL-6, which is why a lot of these JAK-STAT inhibitors appear to have an IL-6-like, shall we say, profile. And there we're thinking about the acute phase response, T-cell differentiation, and lipid metabolism, because of course we know that when inflammation is decreased, we also see that the lipid particles become healthier. They become smaller and more easy to solubilize and also basically transport. And then if we're looking at the interferons that are associated with infection, so antiviral immunity and NK cell activation, we think about JAK1, JAK2. We also think about JAK1, TYK2. We also think about JAK1, JAK2 for interferon gamma. And that means Th1 differentiation and essentially macrophage and NK cell activation also. And then finally, we have the JAK1, JAK3. And there we're looking at lymphoid and maturation and function. So as you can see, Tofacitinib, Ruxolitinib, which is also known as Jakafi and was the first of the JAKs to be approved in the United States in basically myelopoiesis and thrombopoiesis types of events. And then Baricitinib, which was just reviewed at the FDA panel earlier in the week. And then finally Tofacitinib, which was in trials in the US, but is now going to be developed only in Japan. And those are kind of considered to be pan-JAKs, because essentially their effects really do affect all of these pathways. And although they have different IC50s and ex vivo enzyme studies and so on, what we see is that they tend to have effects against all these JAK-STAT pathways. Filgotinib and Upadacitinib tend to be much more JAK1 specific, but they also have some JAK2 effects, and you will see that more at the higher doses, but we'll come back to talking about that. And finally, Dermatology was a JAK3 more specifically, and it is no longer in development because it had basically a variety of drug-drug interactions, such as with the statins, which made it not practical to take forward. Now, these pathways are very much overlapping. They're basically used by all cells. They're used by all of these cytokines. And so you never really know where they're being inhibited at any given time and what cell type or what particular cell. So I like to think of them as prolific and promiscuous. And so I am implying that they're like ladies of the night. We don't always know where they are. And I realize that that's an oversimplification, but it's really the only way I can sort of think about the fact that we know these signaling pathways are, the JAKs are being activated by the cytokines upon binding and then going to the STAT, phosphorylating the STAT, and that's going to the nucleus to start various kinds of transcription. And so you could see that these pathways overlap, but also cause a variety of different interactions. The other point about it is that although the JAKs display different in vitro cytokine profiles, and they modulate distinct pathways, as I just tried to explain to you, they do that to different degrees and durations over 24 hours. Consistently, they're not potently or continuously inhibiting any individual cytokine signaling pathway. So it's really unclear, as I said, where they're exactly working at what time in what cells, et cetera. And the other point is that despite some differences, which I will point out to you, they actually appear to respond and have effects in clinical diseases that are highly similar to each other, much less than they are different from each other. But I will point out a few differences in terms of their safety profiles. So if we actually look at the JAKs and STATs that are associated with human diseases, most of these are either a gain of function or a knockout. So if we look at in terms of the gain of function pathways, we see that polycythemia vera, myelofibrosis, and essential thrombocythemia are actually the diseases for which ruxolitinib has been approved. And then if we look at the knockouts, we've learned some things about that in terms of autoimmunity and also IBD and RA and lupus, so that we can see that we're essentially talking about Tofacitinib and Baricitinib here in terms of STAT3s and STAT4s and RA and lupus. So these would have predicted that we might find these kinds of things. Of course, I'm not going to really talk to you about the hematologic applications of these, which are mostly ruxolitinib, but there's also work being done for graft versus host disease, and there's been work done with transplant, particularly with Tofacitinib, where it was given in very, very high doses, 30 milligrams BID, and on top of multiple immunosuppressives in what we give to patients who are getting transplants, resulted in lymphoproliferative disease. What's interesting is once they decreased the dose, they saw no further lymphoproliferative disorders, and in the control group, which was on all the other background therapy, we started to see emergence of lymphoproliferative disorders. So it probably isn't altogether specific for either Tofacitinib or any other JAK-STAT, but a reflection of the massive amount of immunosuppression these patients were getting. Now, if we talk about the arthritis indications, this is, I think, my only rheumatology slide. So I'll probably not be as accurate about all the other diseases, but I do know a little bit about psoriasis. So rheumatoid arthritis, we know Tofacitinib was approved in Europe recently, but in the US back in 2012. It's approved at the 5 milligram BID dose, but it is available as the extended release 11 milligram dose, and that is unit dosed, so that in fact you are able to give 2 tablets a day should you wish for the same price as 1 tablet a day, but that's determined by medical practice. And why am I bringing it up? Because the FDA included the PK data for the higher dose in the label, thinking that people may well use it because they want to employ their ability to practice medicine. Baricitinib was approved in the EU for both the 2 and the 4 milligram dose. The re-review by the FDA Arthritis Advisory Committee meeting on April 23rd was of great interest and also very long. They spent a lot of time debating about it, and in the end, they voted 10 in favor and 5 against for the approval of the 2 milligram dose, and 5 in favor and 10 against for approval of the 4 milligram dose. And most of the concern was that there may have been some differences in efficacy between the 2 and the 4 milligram dose, but they both appeared to be effective. The 2 milligram dose was only studied in 2 of the 4 phase 3 studies. But the concern was that there was an excess of DVTs and pulmonary emboli, and particularly in the first 16 weeks, there were 6 associated with the 4 milligram dose and none in the placebo group and none in the 2 milligram dose group. And there was quite a bit of discussion about all of that. So I will come back to that when we talk about safety. For psoriatic arthritis, Tofacitinib was recently approved in the US at the 5 milligram BID dose. Again, the 10 milligram dose has not been approved. Upadacitinib has had 2 phase 3 randomized controlled trials already reported out, and 2 more, actually 3 more, are underway. The 2 that have been reported out, and there will be one coming up in Europe at the EULAR meeting, were in the DMARD-IR and biologic DMARD-IR populations. And then Filgotinib has basically phase 3 trials underway. That is a mistake, sorry. Spondyloarthropathy is a bit interesting. We would have thought that Tofacitinib would be very effective, and it had a positive phase 2 study, but it was an adaptive design, and they elected not to take it forward, although there was an article and an editorial recommending by the spondyloarthropathy group in Europe that it should be considered as an effective therapy. Upadacitinib has a phase 2 trial underway, and Filgotinib also. And finally, JIA, Pfizer has initiated a large phase 2/3 study in youngsters with juvenile polyarticular inflammatory arthritis. And that should be sufficient for approval in a pediatric population when you have approval for adult rheumatoid arthritis. Now, the dermatology indications we're going to go through in a little bit more detail. Atopic dermatitis, we have phase 1 with a topical, Tofacitinib, and phase 2 trial that was positive. Baricitinib has phase 3 trials underway. Upadacitinib had a phase 2 that was positive, and that was one of the questions, pre-questions. And ruxolitinib, they're now looking at it in an open-label topical formulation. Oclacitinib has been incredibly important in canine atopic dermatitis, where dogs have terrible itching and literally scratch and get rid of all of their hair because they're so uncomfortable. And it's been seen as a remarkably fantastic drug. Alopecia areata, I'm going to show you some really interesting slides. And so you can see here that we're looking at topicals as well as both as baricitinib as an oral agent. Psoriasis, Tofacitinib had a complete development program, which I'll show you a little bit later. It was decided that the 5 was not sufficiently effective because it was inferior to etanercept, but the 10 milligram dose was non-inferior to etanercept. But the FDA issued a complete response letter indicating they were not going to approve it because a 10 milligram dose had not been considered safe in RA, so they did not think it should be considered safe in psoriasis. Hopefully that will be revisited with the data that's coming out that I'm going to bring up in a few minutes. And finally, ruxolitinib is moving along. And then there are case reports for vitiligo, chronic actinic dermatitis. There's a trial with Tofacitinib, erythema multiforme also, and then finally graft versus host disease, as I mentioned before, already is being used off-label, and a positive survey of its use across the EU centers that do transplant. And it's been a very effective and a murine model of GVHD. So you can see that these are really spreading out. And what's interesting is that all of these diseases are variable manifestations, which actually affect different JAK-STAT pathways, and yet we're seeing very similar efficacy across these different diseases. And so again, an illustration of the fact that these are These are promiscuous and prolific pathways. Well, here's atopic dermatitis. And remember that until recently, we only had ineffective therapies, and pruritus, of course, is one of the major problems with atopic dermatitis. And so we see here 6 patients who had failed standard treatment, and this is the improvement you see in one patient with incredible reduction in both pruritus and loss of sleep due to the treatment, and a 4-week trial with topical 2% ointment. And here again, we see that change from baseline in the eczema area and severity index, or the ESA, was really quite remarkable and very quick. It was also corresponding to improvements by physician global and pruritus. And actually, in this particular small study, there were more adverse events with vehicle than there was with the active formulation. Here is the study with Upadacitinib, after which the FDA granted breakthrough designation, breakthrough therapy designation. And you can see here that they're looking at the high dose of 30 milligrams and the high dose of 15, or moderate dose of 15 milligrams, which correspond to their 2 higher doses in phase 2 with RA. And this is now an extended release, so again, it's a once-a-day formulation. And you see very effective responses here without much difference between the 2 doses. And that's turning out to be true also in RA, that essentially sometimes the 15 is just as good as the 30, and they're only in certain situations or certain patients where we see some benefit for the 30, although we still are seeing that the 30 milligram safety profile may be a little bit worse than the 15 milligram, about the same as I would say between the Tofa 10 BID versus the Tofa 5 BID. And again, when you look at the long-term safety with Tofa, with 20,000 RA patients now since they finished treatment in the phase 3 studies, about the only real difference between the high and the low dose is the incidence of herpes zoster, of which most of it is not disseminated nor multidermatomal. Here is 2 retrospective series in alopecia areata, and I think the pictures more or less speak for themselves. When they did a retrospective study of 90 patients, they identified 65 potential responders, and 77 of them had really dramatic clinical responses. And we've also seen this in patients who we've been treating for rheumatic disease who also have alopecia areata, and it's been quite dramatic. I mean, they're suddenly sprouting hair almost everywhere. And I think you know that alopecia areata is a very refractory disease to try and treat. There was also a retrospective study of 13 adolescents, and they had 92% of them had clinically significant hair regrowth, as you can see in the bottom 3 pictures. So very well tolerated, again, a very promising therapy. Here's the psoriasis phase 3 development program with Tofacitinib. They were the OPT, or oral treatment of psoriasis trials, OPT 1 and 2, and they had randomization to 5 or 10 or placebo, and this was a 2-to-1 randomization. And then week 16 was a placebo rescue, and the standard outcome measurements, PASI 75, and a physician global of clear or almost clear or 0 to 1. At 12 weeks, the 10 milligram dose was certainly better, and the adverse events were similar. When we looked at the long-term extension, this was also very similar, and you can see that the mean daily dose was about 18 milligrams, so therefore there was a preference for the higher dose. In the phase 3 study that had a treatment arm against etanercept, Tofacitinib high dose was non-inferior. I'll show you the data. And this was a very large study of 1,106 patients. In the other study, if they were responders, then they were withdrawn and retreated, and that retreatment was to look at whether it should be 5 or 10 milligrams. And again, if they were responders, they either continued the treatment or stopped and received placebo. 50% of the responses were recaptured with the 5 milligram, but 70% were recaptured with the 10 milligram, showing that it's a preferred dose. The safety profile was similar to RA, but there was much less difference between the 5 and the 10 in terms of tolerability and adverse events. And as I said to you already, that we're still waiting and hope for approval when the 10 milligram BID dose is ultimately approved for rheumatoid arthritis. These are the two phase 3 randomized trials showing the PASI responses 75% and the physician global 0 to 1. And you can see that the studies are quite replicative of each other, but they clearly favor the 10 versus the 5. And then if you look here, you'll see that etanercept is in the aqua color, and it's actually just between TOFA 5 below it and TOFA 10 above it, or TOFA 10 not distinguishable, basically in physician global clear or nearly clear. And here to just show you the numbers, you can basically see that the 5 milligram dose is really not sufficiently effective in psoriasis, that we really need the higher dose. And that's also the difference that we don't see with psoriatic arthritis. But when I get to the psoriatic, or I won't get to the psoriatic arthritis data, I just want to remind you, everybody was on background therapy in the psoriatic arthritis trials. And so basically that would say that we would likely not see a difference, because we've already seen in RA, in the oral strategy study, that Tofacitinib monotherapy at 5 was not non-inferior to adalimumab plus methotrexate, whereas Tofa plus methotrexate was non-inferior and essentially almost equivalent to adalimumab plus methotrexate. And so, of course, we would have liked to have seen the 10 milligram monotherapy dose as a comparison, but that did not happen. This is a phase 2 trial with Baricitinib, again showing you some very similar type of picture. The higher doses tend to be better. They did the 2 and the 4, but they also did 8 and 10 milligrams. And essentially the PASI 90 responses and a higher level of response were seen at the 8 and the 10 milligram dose. And these responses were very well maintained. And then again, when they were non-responders or partial responders, they could get PASI 75s with the higher doses. Adverse events, again, were very similar, but they were tended to be higher with 8 and 10. And there were dose-related increases in decreases in hemoglobin with the higher doses. And we'll come back to some more of the safety in a minute. Here's topical ruxolitinib in psoriasis, and I just thought these pictures were sufficiently dramatic that I didn't need to say any more. And so that is moving forward. And I think that it'll be interesting to see. They did a lot of science behind it to understand what was really being inhibited. And of course, as you might understand, there was inhibition of Th17 and dendritic cell activation and reduced cellular infiltrate into the dermis. So the gastroenterology indications are even more interesting. Tofacitinib had a phase 2 randomized controlled study in Crohn's disease, which failed. And we can only probably guess that perhaps there wasn't sufficient evidence of disease activity at baseline, and so there were not dramatic responses. This is a problem, obviously, in Crohn's disease, where it's being increasingly required that you have to have endoscopic evidence of active disease, and then there's always an argument about how much evidence, because even if you have only one lesion, that may be sufficient evidence, and that's certainly not what you want to be looking at for responses in Crohn's. Upadacitinib and Filgotinib are both in phase 3 with Crohn's disease. And then ulcerative colitis, there was an advisory committee meeting for Tofacitinib, and that was April 8th. And basically they looked at the OCTAVE Induction 1 and 2 trials and the sustained maintenance trial. And what's very interesting here is that this advisory committee voted unanimously to approve Tofacitinib, but not just at 5 and 10 milligrams BID, but also at the 15 milligram dose, which was studied in phase 2. And I'll show you that data. So hopefully that's going to also be another reason why we can get the 10 BID dose approved in psoriasis and rheumatoid arthritis, and hopefully also psoriatic arthritis. And then, of course, Upadacitinib and Filgotinib are moving forward in ulcerative colitis as well. So this is the Filgotinib phase 2 induction and maintenance trial. It was called the Fitzroy. And essentially, these were people with ileocolonic or ileocolonic Crohn's disease for at least 3 months. And these were, as we already know, experienced patients by and large. The CDAI was looked at for definitions of essentially remission or less than 150 at week 10. So again, a very rapid pathway of improvement that we've seen across all the JAK stats and all the diseases that they've been looked at. And they also had statistically significant improvements in the IBDQ, the quality of life for IBD. And you can see here the difference between filgotinib and placebo in the scores and also in the IBDQ below that. And essentially the pooled safety from 0 to 20 weeks was very, very well tolerated and very close to small differences between active and placebo. So now phase 3 is underway. Now if we overview the Tofacitinib clinical development program, essentially this was sort of the summary of everything by both the FDA and by Pfizer at their committee meeting. Robust, clinically meaningful induction and maintenance treatment in patients with moderate to severely active ulcerative colitis. During induction, they used 10 milligrams BID. They had planned to have 15 milligrams as well, but the FDA asked them to stop that. But basically, if you were looking at induction with Tofacitinib 10 up to 8 or 16 weeks, if they were only partial responders, you got benefit in 3 out of 4 patients. It was very robust 8-week efficacy in the 10 milligram dose with very rapid onset of benefit as early as week 2. If you took the partial responders and prolonged the induction, then you got a gain in more than 50% of the partial responders. And then maintenance Tofacitinib in the responders was effective at 5 milligrams BID in many patients, but the 10 milligram was much better for maintenance. And so they saw that that was particularly true for prior TNF failure patients, as we might guess, and that the persistence was up to 2 years, but again, it was better with 10. And if you did dose escalation and retreatment with 10, you could recapture therapeutic benefit in those that had lost it, whereas it was very difficult to do that with the 5. So the phase 2 trials had the 15 milligram BID dose in it, and the data for it were very, very convincing. So it was unfortunate that they were asked to remove it in the phase 3 trials after they had started it. Basically, the statistically significant at the 15 milligram dose with a response of 75% versus 42% in placebo, and remission was evident at both 3 to 10 and the 15 milligram doses that were also studied. If you look at the phase 3 data, and you can see some graphs down at the bottom, basically we see good induction, and then we see maintenance, particularly with the 10 milligram dose. And the defined maintenance, of course, was a Mayo score still less than or equal to 2, and an IBDQ at 52 weeks that showed improvement. There were more infections, serious infections, and herpes zoster, and non-melanoma skin cancers, and MACEs with the Tofacitinib doses versus placebo. But we'll come back to that when we look at the safety profiles. So if we then talk about other autoimmune disease indications, the autoinflammatory diseases, it's very interesting that Lilly has a compassionate use protocol for Baricitinib, which is something that's being moved along for diseases that have no treatments and makes a lot of sense. And then there's some very interesting case reports with both ruxolitinib and Tofacitinib in gain-of-function mutations, such as the STING condition, which is a stimulator of interferon genes. If we look at lupus, what's rather interesting here is that we've got all of the currently known ones being in development, but actually Pfizer has had 3 phase 1 trials in lupus, but it keeps developing what they consider to be JAK stats that are more specific for lupus, so it'll be interesting to see what ultimately goes forward and continues. Baricitinib had a phase 2 trial listed as completed, but I couldn't find any data for it. Filgotinib basically is in phase 2, and they're doing a specific membranous nephropathy trial in patients with active cutaneous lupus as well. And then there was this GSK product, JAK stat, that was in phase 2, And that was actually discontinued because it caused LFT elevations and DRESS syndrome, which is a drug reaction syndrome associated with eosinophilia and systemic symptoms, and is no fun to have if we were talking about pruritus. Primary Sjogren's syndrome, they're looking at both eye drops and topical. Filgotinib has been studied, but again, it was studied against a GSK product, which is a different one, or Trebrutinib, and I could not find any data for that one. And then there are case reports in dermatomyositis, which are actually quite dramatic. Giant cell arteritis, Baricitinib has a phase 1 open-label extension, and Upadacitinib will be studied soon. And then they're looking at Tofacitinib in early diffuse systemic sclerosis, and active non-infectious uveitis is being looked at with Filgotinib. So again, oral agents which are not immunogenic and also quite convenient to take with really rapid onset of benefit across all these different indications, very exciting. So now we come to the other side of the coin, which is the safety of these agents, and basically, I'm going to say to you again, they're more similar to each other than they are different. There's some small differences between them. So if we look primarily at the extensive clinical development programs in RA, even if we are only looking at phase 2 with Upadacitinib and phase 2 with Filgotinib, we're seeing a safety profile that's actually similar to the TNF inhibitors with a few notable exceptions. There is a concern about serious infections, but overall, there's not an increased incidence of serious infections with the JAK inhibitors versus the TNF inhibitors. The TNF inhibitors range between about 3 to 4, 4.5. A little higher with infliximab, and then if you look at rituximab, it's higher still, so you're getting up more in the range of 5 per 100. But we actually see more like 3 with the JAK inhibitors. And we see much less if there's no background therapy. But of course, most of our biologic studies were done with background therapy because of immunogenicity. And so we did a very careful systematic literature review and looked at all of the trials and divided them into those that were with or without background therapy. And the incidence of serious infections goes down to about 1.5 to 2 when there's no background therapy. So just to remember for us rheumatologists, we think of methotrexate always or leflunomide as background. It does still add some risk, even in low dose. The incidence of herpes zoster is increased with all of these, and the particular risk is in Japanese and Koreans based on GWAS studies. The GWAS studies have not been linked yet to specific in vitro assays of mechanism, but we could suspect several things that make it clear why we would see these in Japanese and Korean patients more than elsewhere. Of course, in general, there's an increase in reactivation of herpes zoster as the baby boomers have grown and as the patient profiles have become different in our trials. But this is still a class effect, and we see it in all the agents, and we see the incidence of herpes even in phase 2. The malignancies are generally similar to what's been seen with TNF inhibitors. There's still the concerns about non-melanoma skin cancers and also about lymphomas, but I actually think in RA, we think that these are more disease-related than they are treatment-related, and that's been pretty much our conclusions. When we look at lipid changes, these are LDL, HDL increases, little lipoprotein, little a goes down. These appear to be more related to the precipitous drop in CRP, the decrease in inflammation that we see with these agents that occurs very quickly within a week or two of starting therapy, so that the atherogenic lipid profile actually becomes less pathologic and more healthy. And in fact, if you look in the Tofacitinib database of 20,000 patient years of exposure now, we see that the incidence of MACEs is very, very low. There is a newly emerging profile of thromboembolic events, DVTs and pulmonary emboli, which are thought to be related to JAK2 inhibition. And I'll come back to that in a minute. It's been seen with Baricitinib. It was the issue at the FDA panel meeting. It's also been observed with Upadacitinib. And I'll come back and talk to you about what's theorized to be the etiology for that. GI perforations are a little bit more common than what we've seen with the TNF inhibitors historically, but much less than what we've seen with tocilizumab in their trials and what we also have seen in observational registries across the world. Tocilizumab has a distinct increased incidence of GI perforations, which actually for you rheumatologists we haven't seen with sarilumab. But again, the studies were much smaller and the inclusion criteria, exclusion criteria were much more specific. The laboratory changes do require monitoring. There's a lot of discussion about it. For us rheumatologists, it's no different than when we use any of our other agents, except maybe apremilast. But the hematologic parameters should be looked at. There are various changes that are associated with improvements in inflammation with these various JAK inhibitors, and I'll go back over that. And then there is a platelet effect with Baricitinib, which I'm going to mention when we talk about the DVTs. LFT elevations are variable. Some of these products have more than others. Again, with Tofacitinib, which has the largest database, we don't see them with monotherapy. We see them only with background methotrexate. I won't say only. I say we largely see them only with background methotrexate. And most of the time, these changes are very similar to what we see with the IL-6 inhibitors. That's certainly true of HDL and LDL, and it corresponds very quickly to the precipitous drop in CRP. CPKs and serum creatinine increases have occurred. The CPK doesn't appear to be associated with any myositis or myopathy, and the serum creatinines appear to be idiosyncratic because, again, you look across the Baricitinib or the Tofacitinib databases, there are no incidences of renal failure that can't be explained by another problem such as sepsis. So now this is the patient years. I hope you can read this. Patient years, SIEs, OIs, tuberculosis, herpes zoster, both non-serious and serious. Again, the minority are serious. Malignancies, excluding non-melanoma skin cancer, lymphoma. Then you see non-melanoma skin cancer, MACE, DVT, pulmonary emboli, and GI perforations. The red line indicates that Filgotinib and Upadacitinib data are from phase 2 trials, so it's a much smaller database. But you can see with the Tofacitinib database, it's 19,406 patient years. And for Baricitinib, it's 6,637 patient years. So now you can look across these and you can see that they're really not very different from each other until we actually get down to DVT, pulmonary emboli. And there, across the large Tofacitinib database, the incidence is 0.1 per 100 patient years. And for Baricitinib, it's 0.6 for the 4 milligram, and it's 0.5 for the 2 milligram. And then you can see for Filgotinib, it's 0.12, but there's also a signal, albeit still a small patient number, with Upadacitinib of 0.7. So again, that seems to be the difference. It's thought to be a JAK2 effect. So JAK2 is mediating thrombopoietin and erythropoietin. The question at the advisory panel, and this is a very interesting discussion with no final answer, is that it could be that this inhibition is now meaning that there are effects such that the platelets production is increased, but you don't see an increase in mean platelet volume, which you would expect if you were seeing more megakaryocytes if production was increased. So the alternative theory was that, in fact, this JAK2 inhibition is now affecting the clearance of platelets. So, in fact, your platelet number goes up, and that is what occurs with Baricitinib. There's a distinct increase at 2 weeks, which then comes down by 4 weeks, and they remain elevated from baseline, but not very elevated. So that initial increase is only for the first month of treatment. Now, the discussion was also, is there a relationship between platelet number and DVTs and pulmonary emboli? And the hematology expert basically said, we've never seen that type of relationship, and we don't have a good way of hypothesizing how that could occur. So whether this is an effect on the clearance of the platelets or it's an effect also on their production, there does not seem to be a link to that. Now, overall, the concern is that, well, DVTPs occur in rheumatoid arthritis patients, and the incidence is somewhere between 0.3 and 0.7. So why are we worried about an incidence of 0.5 or 0.6 when only one of the 42 events that were ever reported with Baricitinib was fatal? But again, this was a panel that was not very clinically oriented, and I think they were more concerned about hypotheticals than they might have been concerned about the fact that they've seen DVTs and PEs in their patients before, and they know to treat them. There was an epidemiologic study that was requested by the FDA and done by Lilly, but unfortunately, the FDA immediately got up and discounted it as saying, well, it's a totally different patient population. It's not relevant at all. It includes people who also had been on anticoagulants because they'd had previous DVTs or PEs, and so we discount the data. Furthermore, trial populations are generally healthier than patient populations that you see in observational studies, so we don't know what the incidence in that study could mean compared to the incidence in the trials. And then furthermore, there were none in placebo and there were none in the 2 milligram dose in the first 16 to 24 weeks. So I don't have a good answer for you, but because we also see this with Upadacitinib, I do think that there is a JAK2 association, although I don't think I can convincingly prove to you that I know what the mechanism of that action is. There's also, if we look at mean changes in laboratory parameters, we'll start with decreases in hemoglobin at high doses. That's a JAK2 effect too. And we've clearly seen that both with the high dose of Baricitinib and the high dose of Upadacitinib. Is it clinically relevant? It's hardly ever clinically relevant because hemoglobin is so tightly regulated that basically we may see decreases, but they still stay within the normal range. And we've looked at this for years with IL-6 inhibitors and with trying to understand the anemia of chronic disease. So yes, you have to monitor, but it's really not a major effect. You see lymphocyte decreases, essentially with Tofacitinib and Upadacitinib. Those are usually right as you start the drug, and they may actually be sort of a biomarker of response. Very, very few patients become lymphopenic. The label for Tofacitinib says that you should monitor if they're below 500, you should hold the dose, and that it might be associated with viral infections, but the association is not very clear. NK cell numbers do go down, apparently not with Filgotinib, which is not as effective as in terms of the other JAKs as it is for JAK1 inhibition. There are some changes in neutrophils with Upadacitinib, particularly at the high dose. If you look at platelet counts, we've seen that the platelet counts with Baricitinib go up, and then they go down, but they stay elevated. You see an effect on platelets also with Baricitinib at the high dose, but it hasn't been as well characterized yet. Liver transaminases, I have it down as increasing with Tofacitinib because the majority of the trials were done with background methotrexate or DMARDs, but that's true of all of these. Apparently, there doesn't seem to be such a change with Filgotinib. HDL and LDL go up, CPKs go up, but are really not associated with clinical events, and creatinines go up idiosyncratically. They should be monitored, but so far we've not seen any renal events that can be attributed to a JAK inhibitor. So if we think about the overall clinical conclusions, all are effective, been studied across a wide range of IMIDs. There's a really early onset of benefit. We can see it in terms of patient-reported pain. We can see it in terms of patient-reported outcomes. The global disease activities go down. They actually plummet. So do the pain. And, within the RA studies, we can see ACR 20s within 2 weeks and ACR 50s within a month. And the predominant efficacy for all of these products has been at weeks 12 or 16, where they're already very effective. So if it's not working by week 12, I think you can firmly say that perhaps it's not effective in that particular patient and that particular disease. I talked to you about the strategy study with Tofacitinib, where monotherapy wasn't as good as adalimumab plus methotrexate, but they didn't try the high dose. Again, in PSA, Tofacitinib was quite comparable to adalimumab, again, with methotrexate in their study. And psoriasis, Tofacitinib 10 milligram was non-inferior to etanercept. So what's really kind of interesting is all these different JAK selectivities, we really see very similar safety and efficacy profiles. I think we have to now call out this JAK2 effect that we see that apparently has an effect on platelets in high doses on hemoglobin levels, and also an association with DVTs and PEs. although I think the association is not as clear as we'd like to be, because I don't think we really mechanistically understand how we can call it a JAK2 effect per se. I think we have to worry about LFT elevations with monotherapy with Filgotinib and Upadacitinib. And then, as I said to you before, the zoster is well recognized, and the nice thing about getting the new zoster vaccine is that you can actually be vaccinating patients who are already receiving their therapies, their DMARDs, their biologics, or even their JAK inhibitor, because it is a killed virus and there will be no concern about reactivation or dissemination. So essentially, I hope that this has been helpful, trying to talk about a very complicated pathway that seems to uniformly be a very effective target across all these different diseases. And I would also like to conclude that I think it's a pretty acceptable safety profile. All of these products have short half-lives, which is why they've been formulated in extended release if they need to be taken BID, because actually the half-life of Tofacitinib is 7 hours, and so in fact, if you stop 24 hours, the drug is essentially gone. Now, for the extended release, it'll be a little bit longer, but the point being that you may still see the biologic effects, but the drug is actually not having an effect in vivo, and then it's a matter of just looking at the reversibility of the biologic effects. So in many ways, this may be part of the reason why these serious adverse events of serious infections and so on actually resolve, and that a variety of things that have been associated with the JAK inhibitors in terms of tolerability or safety actually also reverse very quickly.